let me introduce our next speaker, who is Professor Dr. Bernhard Schiefer. He's director at the University Heart Center Department of Cardiology, Angiology, and Critical Care Medicine, University Hospital in Marburg in Germany. He will talk about targeting the HDL proteome for the treatment of post-COVID syndrome. Welcome, Professor Schiefer.
More clinical point of view from my side and a therapeutical way how we think that we could target the post-COVID symptoms following SARS-CoV-2 infection and also following vaccination side effects. I have no conflict of interest, and I have no conflict of interest and received some speakers honoraria from various pharmaceutical companies. In 2020, COVID-19 was first came into our clinical view, and two of the godfathers of vascular diseases in atherosclerosis, Peter Libby from Boston and Thomas Lüscher from Zurich, first published in the European Heart Journal a paper where they described the endothelial damage, something what we heard already from Rizia Pretorius a couple of minutes ago. But this is not only a topic of endothelial cells, it also involves the whole layers of the vascular wall, including hepatocytes, which are responsible for the inflammatory amplification by cytokines like IL-6, and which is also a rate-limiting step when it becomes to the step of degradation of anticoagulants and procoagulative substances released from any cell type within the human body. The proof of principle that parts of the SARS-CoV-2 virus contribute to vasculitis came from the Salk Institute, where Uri Mainer first described and showed here very nicely in this immunohistochemistry slide that the spike protein, in fact, is located within the vascular wall in between endothelial cells. Similarly, where cholesterol deposits develop in atherosclerosis, and he first addressed the issue that SARS-CoV-2 is not a respiratory disease. It's more like a vascular disease. Similarly, what we know from vasculitis diseases like lupus and Sjögren's syndrome. More recently, Peter Karmelin from Leuven University, he even dramatically described how a simple respiratory virus infection may turn out to be a complete disaster for the vascular bed, including proposed mechanisms like inducing a vascular leakage, initiating coagulation, promoting inflammation by presenting adhesion molecules, amplification of the cytokine storm. This disease turned out to be composed by all components a traditional sepsis disease, and this is something which may contribute in the long run to the development of post-COVID symptoms, including cytokines like IL-1 beta and TNF alpha. more advanced Eric Topol, he then described that long COVID, major findings, and he associated these clinical findings first with additional symptomology and pathology, so that he associated the chest pain, which we know from our long COVID patient, by myocardial niche inflammation, and he also associated palpitations with POTS and cardiac impairment. Similarly, MCAS and diabetes and were associated with pancreas injury. But for us in the clinical setting, the question remains how we could treat or try to treat these long COVID, or afterwards, after 12 weeks, the post-COVID symptoms. And what I would like to present now is the simple cardiologist's view on the treatment of these symptoms. One of the obstacles and hurdles is that patients present on a daily basis with different symptoms. This is difficult for physicians to recapitulate the disease development in one individual patient. And the other obstacle is definitely our traditional physician's view that whatever my specification as a trained physician is, that's the main focus of my treatment regimen. The next obstacle is something which Carmen Scheibenbogen described recently, is that biomarkers are completely lacking and clinical symptoms hardly match with traditional biomarkers, even though we have good questionnaires to classify the patient. If we have, except brain natriuretic peptide, a peptide which is released from the heart when it's failing, then we have a stronger association, but all cytokines and other traditional biomarkers are completely lacking their efficacy in the prediction of the disease development. One additional obstacle is that the SARS-CoV-2 immunology, humoral and cellular immunology, follows different combination following vaccination, breakthrough infections, and this is something what Hendrik Streeck a year ago presented very nicely in Nature Communications, where you have hardly any immunological residues in common from one patient to the other. And the question for the clinician remains, how could we treat these kind of patients in a systematic manner? What we try to do is we try to cluster the patients, and we did this by combining questionnaire and laboratory specimen selections. So we took blood from the patients and had about 150 lab markers, and combined this with the questionnaire and asked our AI-based mathematicians to combine these results in order to enable the creation of and differentiated patient profiles. We obtained 4 separate groups of patients, and we could also identify patients which need further clarification. This is the blue one. And these patient groups we used for clinical evaluation and clinical testing of therapeutical strategies. So how can we treat patients with post-COVID? We had a treatment hypothesis which is based on the knowledge that targeting one single molecule at one time point is not sufficient enough and will not give us any further clue of how to treat these patients. Rather than our treatment hypothesis was targeting biochemical pathways and biochemical systems which are essential for the development of the disease, A, and B, for the mediation of inflammation in this clinical setting. And we came up with the idea that the renin-angiotensin system, one of the most preserved systems of human blood pressure regulation and inflammatory regulation by angiotensin II and pro-inflammatory and acute phase proteins like angiotensinogen stimulated pathways, is one of the most conserved pathways of blood pressure regulation, as I mentioned, and also of inflammation. And our idea was targeting this, and this is not a new idea. About 15 years ago, we performed a double-blind randomized trial using antagonists against mediators of inflammation, namely the cholesterol subfractions, plus treating the renin-angiotensin system. And by treating these patients in a double-blind manner, we could show that lipid peroxidation as a mediator of inflammatory endothelial disease could be targeted successfully and significantly reduce clinical and biochemical events. This has also been tested in an observational manner in San Diego, and this is one of the first results using ARBs and statins in a clinical setting of COVID-19. And the colleagues from San Diego could demonstrate that the time to severe COVID-19 and also the time to recovery could be reduced when patients were pre-treated with statins plus AT1 antagonists. Similarly, over 700 patients in Singapore also treated for a COVID-19 infection. Statins plus AT1 antagonists published in 2020 were successfully been shown to reduce disease severity and enhanced recovery of these patients. And the scientific background is known for a very long time. Here is a paper from Otake in Circulation in 2021. Cholesterol subfractions, particularly the high-density lipoproteins, alter through when the patient is going through an inflammatory process, regardless which one. And this HDL subfractions, the HDL molecule, is not a simple molecule itself. It's a composite of different lipoproteins, and it acts like sticky glue. It floats via the blood flow through the, it picks up all kinds of proteins and peptides circulating, and it incorporates, transfer it to the liver, and where these components will be degraded, and a native HDL is then again released into the bloodstream. Therefore, HDL modulates not only lipid raft structure in immune cells like B cells, T lymphocytes, and particularly monocyte macrophages and dendritic cells, which are hiding in vascular and organ niche subfractions. So you could target monocyte macrophage and dendritic cells by treating HDL as a cargo carrier, and it modulates, as shown here in this very nice review from Catapano, by activating or downregulating receptors of immune cells. Moreover, it's also important via the combination of ApoA content, that the differentiation and maturation, particularly of dendritic cells, which is important for the chronification of immune processes and the impact of antigen presentation, ApoA1 containing HDL could modify the function of dendritic cells and B cells. This has also been described in the context of COVID-19, where this very nice review by Kluck and colleagues in 2021 first speculated that this COVID HDL containing a subset of acute phase proteins together with components of oxygen-free radical producers like panoxinase 1 and 3 and oxidized triglycerides may have turned into from a good guy to a bad guy, and that's why they entitled their paper The Good Cholesterol Turned Out to Be Bad. Our clinical view is away from the pure atheroprotective against plaques to a guardian angel within the bloodstream, which takes apart the pro-inflammatory mediators, but once it's filled up with acute phase proteins like in the COVID HDL with saturated content of SAA, then this cholesterol molecule turns out to be bad. So the very simple view of cardiologists on the HDL proteome, on the HDL molecule and the containing proteins is that it's nothing more like a vacuum cleaner booty, and it's something which we could use as biomarker as well as a crystal ball and take a deeper look into maladaptive biochemical post-COVID processes in a time-dependent manner. So when looking at the HDL proteome, we do not have to consider anymore at what time post-infection the patient is, what comorbidities he has. We have most probably, when using the HDL proteome analysis, we have a simple but very precise view into the patient. And so for us, it was when we thought about a pilot trial treating patients with post-COVID symptoms, we considered the so-called reverse cholesterol transport, meaning the pickup of all kinds of peptides and protein debris in the circulation, stick to the HDL protein, to the mature HDL protein on its process on its way to the liver for degradation and recirculation. We considered these HDL particles as a target and a monitor for our treatment success. And we designed a very simple treatment trial where we selected patients according to the patient selection, AI-based patient selection I showed you in the last slides. And we selected post-COVID patients and post-vaccination patients and treated them for 6 weeks with an AT1 antagonist and a statin and monitored post-COVID symptoms.
Professor Schiefer, please come to an end.
Post-COVID symptoms, performed an HDL analysis and could demonstrate that the clinical symptomology is reduced and the cholesterol and blood pressure levels were also reduced, and markers of endothelial inflammation were significantly reduced when endothelial cells were stimulated with HDL. significant proteins were identified between control and patients, as you see here in the heat map and in the volcanoplots. And one of the most interesting peptides which we identified was the ATP-AP6 peptide, something which is involved in platelet aggregation, in antioxidative activity, extracellular matrix, and also in protein maturation, and a process which has to do with focal adhesion, platelet granular release, and endocytic vesicular lumen, and ER transmigration. ATP-AP6 is closely related to the renin-angiotensin system and also involved in the pH regulation throughout all cells in the whole human body. So far from Marburg, thank you very much for your attention.
Okay, well, thank you so much for your interesting presentation, Professor Schiefer. And we will now move on with Q&A with the first question from attendees, which is, could plasmapheresis, immunoadsorption, or HELP apheresis be effective treatment for the vascular and endothelial dysfunctions and more for patients with long COVID and ME/CFS?
Short answer, for post-COVID, yes. For ME/CFS, no. HELP apheresis, yes. Immune apheresis, no.
Okay, thank you. So then, if one has chest tightness and cardiovascular symptoms in long COVID and ME/CFS and they get worse or change, do you recommend regular heart checks?
Of course we do. In order to avoid or to detect myocarditis, so silent myocardial damages.
Okay. Thank you. Then, so the next question. Would you recommend regular testing of heart health, EKG, blood markers like troponin or others when heart symptoms are a part of the long COVID syndrome?
Since we do not know where the inflammatory mediators are damaging the heart, most of the time it's in niche areas in the myocardium, we recommend ECG, echocardiography, and traditional biomarkers like troponin and pro-NT-BNP in order to exclude silent myocarditis, which has been described over 6 to 8 months following a SARS-CoV-2 infection and also following anti-SARS-CoV-2 vaccination.
So, thank you. Okay, then LDL and HDL proteomes overlap. There is evidence that suggests a role of LDL in ME/CFS post-COVID syndrome, for example, with regards to RBC deformability and microcirculation, and better to adrenergically stimulated NAK ATPase as a potential regulator. What makes you believe that HDL and not LDL proteome is the right target?
HDL proteome has been shown in the past to be the more predictive molecule or molecule composition, which shows more, represents more than the LDL, where the problem is. LDL is an important molecule. This is a critical question, of course, but the LDL molecule underlies a lot of variation. And recent evidence from other groups showed that modification of the LDL alone in an animal model doesn't change anything.
Okay, thank you. So another question. How is it possible that some people develop long COVID and some not? What is the difference between them? Tricky question.
That's I mean, I don't know. How should I know? I have my simple cardiology view. I'm so sorry, I can't answer this question. It's way
Hopefully
beyond.
we will find out in the future.
Hopefully. We're all working on it from different perspectives.
Thank you. Thank you. Okay, then we move on to the next question. How does the clinic for vaccine injured define post-vac? Are there blood markers?
So far, there are no solid blood markers for the post-vaccination syndrome. I really have to admit that even though we look in different directions, we haven't found anything which is not at least 90% overlap with traditional post-infection, post-COVID syndrome.
Okay, thank you. So then, are these findings specific to long COVID or also relevant for ME/CFS cases not related to SARS-CoV-2?
We're working on ME/CFS very with high pressure, but I can't give you an answer yet. Maybe next year.
Yes, I'm looking forward to. So, do you think long COVID and vaccine long COVID have exactly the same pathophysiology?
There's a strong overlap. If you look in a time scale after 12 weeks, in the first reaction is extremely important, and there is a discrepancy between post-COVID, which is a viremic, also consists of a viremic response, and the vaccination syndrome. But this normalizes, in brackets, towards a standard post-COVID syndrome complex.
Okay.
Clinically speaking.
Thank you. So something happened to the chat section. I can't see it right now. I can only see the speakers. So tech guys in the background, did you change something? Oh no, it's back again. So can metformin treat the vascular damaging?
Metformin has extremely interesting approaches, and one is that it abolishes the transfer of vacuoles and vesicles intracellularly from the endoplasmatic reticulum towards the cell membrane, and it also normalizes blood pressure, blood sugar levels. These basic mechanisms make metformin a very interesting therapeutical tool in order to improve the symptoms. But it's only for a few patients which have problems with their blood glucose metabolism, and also in the early phase post infection.
Okay, good. Then I think we can ask another question. Any links for VO2 max levels to CFS and long COVID?
Not yet. Not yet. Except lab work, yes, but in clinical setting, no.
Okay. Good. Then we can move on to another question. May the disease lead to heart failure in the sense of HFpEF in the long run?
This is a $100,000 question. I would really like to know, and we're following particularly those patients with a mild and silent myocardial injury, because we postulate that these myocardial co-infection in a SARS-CoV-2 infection, this may lead to dilated cardiomyopathy or any other kind of myocardial damage 10 years, 15 years, 20 years from now. But this is a very long-lasting hypothesis where my grandfathers even were following with other virus infections.
Okay, so then thank you very much for answering all these questions, and thank you for your interesting presentation. We have now reached the end of the Q&A session.